Hello, everybody. I'm Dr. Keith Martin, the Executive Director of the Consortium of Universities for Global Health, and welcome to this webinar, this important webinar that we have today on oral health, one of the most neglected collection of diseases in the entire world. 3.5 billion people around the world are affected by oral diseases. The interesting thing is most are preventable or, in fact, treatable. But it is also very much a collection of diseases that affect the world's poor and the marginalized. The interesting thing is we can do a lot to be able to prevent this collection of diseases, and in so doing, have a profound impact on people's health and socioeconomic conditions. We also know that what we've been doing isn't working, hence the 3.5 billion people who are affected by oral health diseases. So we need to do more. We need to work with our colleagues in dentistry and go beyond that to other disciplines and look at system reform that will be able to improve the lives of so many people around the world. Now, we have an absolutely stellar group of global leaders in this field with us today who are going to be on this panel, and they're going to share with you a lot of very concrete solutions on how to deal with that. So in the order in which they will appear, the first is Dr. Bruce Donhoff. Dr. Donhoff is the Walter Gerling Professor, Distinguished Professor of Oral and Maxillofacial Surgery at Harvard University. And Dr. Donhoff will be followed by Professor Arish Naresh. Dr. Naresh is the CEO of the Omeo District Health Hospital in Victoria, Australia. He's also the president of the International Oral Health Association. Next will be Professor Alan Shi. Professor Shi is the Dean of Dentistry at the National Yangming University in Taiwan. And finally, Dr. Irene Adjidmaka. Dr. Adjidmaka is the chair of CUGH's Global Oral Health Interest Group, so please contact her if you want to join us in this effort. She's also a lecturer at the Maranatha Christian University in Indonesia. So at the end of their conversations, discussions, we will go to your questions, so please get ready to put your questions into the question box and we'll get to them. With that, I will turn it over to Dr. Donhoff. Dr. Donhoff, welcome, and thank you for being with us. The floor is yours, sir.
My pleasure, thank you. So there are three things listed on this slide that's labeled solutions to address the oral health challenge. How did I get into this? It has become a passion of mine, and I'm so pleased to be joining this group of people under the auspices of the Consortium for Universities in Global Health.
Excuse me,
yes,
Dr. Donhoff, could you share your screen, please?
Oh, it's not shared? Ooh. Why isn't it shared?
Do you see the green share screen button on Zoom?
No, I don't. What happened? Should I come out of this?
Yeah, take your PowerPoint out of presentation mode real quick.
Okay.
And then now share your screen on this, if you see it on Zoom, if you can see yourself in the Zoom box.
Now I don't see it. Share screen. There's my picture, but I don't see share.
Underneath it, the green button.
Hold on a minute, let me. Okay, here we go. Now it disappeared. Whoops. It just was working. What happened?
Great, we can see your screen. So if you pull up the PowerPoint.
Pull up the PowerPoint. Okay.
Great, and then put it in presentation mode.
Okay.
Great.
All right.
Perfect, thank you so much.
Sorry. Well, let's get out of this. I've been asked to introduce the topic of solutions to address the oral health challenge today. About 7 years ago, Harvard University began a large global health project, and lo and behold, as is not unusual, oral health, and the dental school was not represented. So we put together a task force that included Julio Frank, who was then the dean of the School of Public Health, Lois Cohn from the NIDCR, several other people, and formed the Harvard Initiative for Integration of Oral Health in Medicine. This has led to the next entity, the Center for Integration of Primary Care. This highlights one very important fact. The word silos has been mentioned, and indeed, education, practice, the healthcare delivery, dentistry, and oral health has been siloized and removed from medicine. The history of that is extremely long and complicated, but I think the delivery landscape, as noted on this slide, is changing. CVS and Aetna working together, but it's not easy. Amazon, JP Morgan, and Berkshire Hathaway had a great plan a few years ago, and it's wound up doing nothing. At least in the United States, something called dental service organizations have grown up to provide business acumen for dental practices. Most of the things that I will say are related to the United States. And in fact, the dental profession is very different in the United States than in many of your own countries. We are looking to develop value outcomes rather than fee for service. And I put this all into the category of disruptive innovations, which are innovations that are maybe not as good as the existing situations, but usually less costly and can lead to some interesting changes. Blue Ocean Strategies is a concept and a book that has turned strategic thinking on its head. And the best example I know of that is, you probably know the great Ringling Brothers and Barnum and Bailey circus that was in America for years. Well, it no longer exists, but Cirque du Soleil has replaced it, a complete blue ocean strategy. The other thing that's happening is many of the retail companies like Walgreens and CVS are going into healthcare. Certainly with the pandemic, their ability to provide vaccinations was very important, but several of them have really started to look at how to integrate oral health and general health, specifically oral health and primary care. And if I have any message today, that will be the big one. So there's been growing interest in multiple reports over the years, and I'm not going to spend a lot of time on all of these, but certainly the big problem for me is there are not a lot of actionable items. So the very well-known Surgeon General's report of 2001 by David Satcher highlighted the fact that dental disease and oral health disease is an epidemic and needs to be stopped. This led to the initiative that I talked about. There also was a 21st Century Guys report to build upon the 1926 Guys report, at least in the United States, that had a cover that was lavender and purple from the academic colors of medicine and dentistry, calling for integration. But indeed, it stopped short, and oral health and dental education remain separate. In recent years, there's been a call for a second Surgeon General's report, but because of the pandemic, that has been postponed. In our country, as in many countries, the aging population has become a very important factor with increased chronic disease. And the Santa Fe group has championed a Medicare initiative. And indeed, in the most recent deliberations in our Congress, there's still a potential for Medicare to be to include a dental benefit. The interesting thing about this is innovations has its own enemies. And sometimes those enemies are the people we know and care for. People get used to the status quo. They get used to incumbency. And so typically the Medicare dental benefit is one very, very obvious example of how the profession doesn't always think of the people that they take care of. Also, you should know of something called La Cascada Declaration, which was put together by a number of senior professors in oral health institutions around the world, which really calls for an integration of education of oral health and medicine. The Lancet report, led by Dr. Watt in 2019, highlighted the importance of the similar things, and the Primary Care Collaborative report, only in March 2021, highlighted the same thing. Every one of these now calls for oral health to be included in primary care. I think it's interesting to look at this as a very slow idea. Atul Gawande, a surgeon here in Boston, had a paper in the New Yorker some years ago where he talked about the difference in introduction of ether anesthesia versus adoption of asepsis by Lister. Ether anesthesia was adopted faster than if an internet had existed back in 1846 because it helped the doctor. The adoption of asepsis wasn't so easy because it created work for people and use of gloves and washing of gloves. This can be carried over to how quickly dental implants were adopted and versus HIV/AIDS. HIV/AIDS has led to one major change that many in the world don't realize. We wear gloves when we take care of patients. I always recall the patient I saw in 1982, I had taken care of before, and I went to take care of a tooth for him to remove it. And he said, "Doc, put on gloves." I said, "Why?" He said, "I just came back from Seattle where I had a bone marrow transplant, and I developed something called graft versus host disease and HIV/AIDS. Well, that led to almost as much turmoil as this pandemic has. But indeed, I would hope that a change like wearing gloves is something that we can achieve from this pandemic in terms of integration of oral health into general health. I think it's interesting to put this in context. Ron Heifetz is a professor here at Harvard University, and he talks about technical and adaptive change. Technical change changes something like a regulation, etc. Adaptive change is really transformational. But the interesting thing about adaptive change is that it always means a loss of something for someone or some group. And I think for the dental profession, the thinking about integration of oral health into general health is just that, because it changes the delivery system from a strictly private office kind of situation, at least in the United States, to a more robust kind of delivery system. Even the American Dental Association has been studying this with the Health Policy Institute, and I'll just draw your attention to the last thing in this slide, which says reform the care delivery model. Get dentistry out of its care delivery silo. And I think that's one of the difficult things to do. John Cotta has written about leading change. And if you look at this graph, and if I were asked, where would I put this, the change that we're talking about on this graph, I would say that we're somewhere between getting the vision right and communicating for buy-in. And that's kind of sad because this has been going on for many, many years. And so I really think we need a catalytic mechanism, some kind, something that will promote the changes we seek. And I think one of the things that can do that is changing the scope of dental practice from dental to oral health. Here are a number of papers, and I will get you to references. The Guy's report came out in 1926. Dental Education at the Crossroads looked at this in 1995, a Institute of Medicine report that was brilliantly done, read by 13% of the profession. In 2014, John McDonough, a public health professor, and myself and Christine Reedy introduced the idea of integrating oral and general health for purposes of education, for purposes of insurance, and for purposes of improvement in patient care. And this has taken off in some sessions. The American Dental Education Association had an Advancing Dental Education in the 21st Century project. And in fact, our own primary care center at Harvard University looked at establishing of a integrated practice, something that we're still trying to do, and had a whole plan devised by Qualis Healthcare. Some of the things that work against us is regulations. Every state regulation, licensure has some kind of restriction attached to it. And although this isn't obvious to everybody, you should realize that in the United States, at least, every dental school graduate must take a licensure exam that's usually 1 or 2 days and may not reflect their best performance. Of course, there are written exams as well, but what this paper by Richard Mansky from the University of Maryland, the first dental school in the world, so to speak, then known as the Baltimore College of Dentistry, which somehow wasn't accepted by the University of Maryland and set the tone for the separation of dental education from medical education for the rest of time. He suggests that there be a relaxation of regulations. And some of this happened during this pandemic. How come pharmacy students were able to give vaccinations in our country, but dental students and dentists didn't? We give big mandibular blocks and a vaccination is a little tiny needle. Something wrong about that. On the right is a picture of Vivek Murthy, our current Surgeon General. This was a paper he wrote about oral health in primary care back when he was first the Surgeon General a couple of years ago. There's been a number of good papers making the case for integrated primary medicine in primary healthcare. This by Monty McNeil, former dean at Connecticut, has run into the pandemic, but has some very interesting possibilities for implementation. And what we need are actionable items. And last but not least, a paper I wrote with the dean of the medical school, George Daly, on the fact that it is time for the integration of dental and medical education, at least to produce a certain group of champions who can promote integration of care, insurance, etc. So the main issues for change: access and disparities of care. You've heard about that. We're developing medical treatments for surgical disease. People won a Nobel Prize in Australia, just to mention Australia again, when they found that antibiotics could prevent gastric ulcers. Well, there are now research with some materials so that caries can be arrested. Certainly, we have to be part of behavioral health and the addiction role, and our aging population and increased chronic diseases is very important. Professor Watts has coined the term multimorbidity in some of the Lancet studies because as people live longer, they have more chronic diseases. There is a huge primary care shortage, and I do believe that The dental profession can help relieve that. And the bottom line is make oral health part of primary care. It's easy for me to say, because you need to understand my background is both in dentistry and medicine into oral and maxillofacial surgery. In fact, my institution was the first to have joint program in both, so that appropriate level of training in general surgery could be obtained by the resident in oral and maxillofacial surgery. So there are a number of things that can be done. So here are the options for change. Interprofessional education and practice. Quite frankly, I'm not a great fan of interprofessional education because, at least in our country, I don't think it really works. Nurse practitioners have been a great example for medicine, and I think if our profession would let dental therapists take their correct role, I think that might help. We certainly can spend years trying to change the practice acts. We can try and change education. And one of the things that I favor is another dual degree to get oral health into primary care with an appropriate residency. So the practice of the future, as we like to call it, should have integrated care, integrated financing, and true interprofessional practice with teams. We know we can do teams. We've had cleft palate teams for years. The use of a team to deal with complex medical problems is not new. It's just something that we need to return to. Here's what's wrong. What's the difference between this periodontal infection and this leg infection? Not much. They're just in a different part of the body. So new pathways, nurse practitioners, physician assistants, dentists helping in chronic disease management, changing their scope of practice, dental therapists, new programs in family medicine and primary care, all can help. And I do believe in these. Oral health in primary care is the goal because of chronic medical conditions, behavioral health, social determinants of disease, team-based cares. COVID-19 has made this even more important. I think the other thing that doesn't happen in our country is there isn't a mandatory general practice internship, just specialties, although young graduates are opting to do this more and more. Other countries I know, and I've studied the educational systems, and others often have what amounts to a year's internship or two. So we believe that we can transform dentistry by removing the distinction between oral and systemic health. This is a picture of our not so new building anymore. And I think at our institution, where our students are part of the medical school for the first 14 months, it's become part of the culture. And I think that's what we're trying to change. So here you see various hospitals where they develop primary care programs for teaching first-year medical and dental students who are together. And you see right in the middle a picture of the red brick dental school. And in fact, we have a primary care practice at the dental school where dental and medical students can learn together in an integrated kind of way. So it's a matter of culture. Clay Christensen, who I mentioned before in Disruptive Innovations, was a great one for examples. And he used to say, if he needed a piece of electronic equipment, he went to Best Buy. If he needed something more for like a Christmas present, he could go to Walmart, where they sold both what they sold at Best Buy and what they sold at the Home Depot. If he needed a snack, he used to have to go to a 7-Eleven. If he needed gas, he went to a gas station. But now he can go to an integrated gas station, 7-Eleven. And last but not least, I think that this is the place to do this. I think COVID-19 is an important factor in pushing us in this direction. And I think it will be meaningful to healthcare, and most important, meaningful to our patients. And I look forward to your presentations because I know there are some wonderful things being done around the world if Americans would only look. Thank you very much.
Thank you, Professor Donoff, and it's a hard act to follow when you've covered quite a lot of topics. So I'll try my best. So I trained in Fiji and worked in New Zealand before moving to Australia. So I'll try and share a bit of the Oceania perspective. And there's a nice segue because I think Professor Donoff has talked about system reform. He's also talked about interprofessional education as well as team-based. So I will focus on 5 key things. The first 2 are aligning with system reform. The first point will be mainly around what we can do as a profession group. The second would be what others can do for us to get oral health on the agenda. And then I'll share 3 what I think would be practical solutions going forward to progress the global oral health agenda and reduce the vast inequities that we have in care provision. And as Dr. Martin said earlier, 3.5 billion people have an active lesion. Now we've had that stat repeated to us for a number of years with very little or no change in the data for the better. So I think the first challenge is, and this is largely for the oral health professions, I think we have for too long thought about this whole concept of we know the tooth, the whole tooth, and nothing but the tooth. And I think it's time we shifted from the paradigm. And I think I picked up on Professor Donoff's comment that we need to change from the concept of a dental team to an oral health team, because it then widens the scope of what we do and brings more professions in. And I think before we expect other professions to partner with us and integrate our work into their work, we need to also expand our horizons beyond the mouth. As I say to the students that I lecture, that if the head wants the body to notice what it can do, it must also show its value. So the second point is what other professions can do to assist us. And I think it takes a very long time to get things on the global agenda. The whole concept of having a global oral health strategy was mooted to WHO as early as 2000. But the first time it's actually made into a draft strategy has been 2021. And similarly, for the clinicians that are online and those that know a lot about fluoride, you'd be surprised that the 3 things that we take for granted in the profession of dentistry and oral health, such as toothpaste, glycinamide Siemens, and silver diamond fluoride, were not even considered essential medications until the 1st of October this year. So it's taken more than 100 years of dentistry and oral health to get that into the main health agenda. So I will share some examples of what I think has worked in New Zealand. Most of my clinical practice was in New Zealand, and one of the things I really enjoyed is how they integrated the early years part. The first 2000 days, as we know, is very important for the child, and I think if we can get the oral health message to the parents, the caregivers, and the wider community at that juncture, we are likely to do much better when it comes to the teeth for lifetime. And we know from the Dunedin multidisciplinary study, which is quoted by many, that your oral health age, the number of decayed lesions you have at age 6 is a good indicator of the number of decay lesions you will have when you're 36. So here is a good example of a program called Lift the Lip, which means that at 6 months of age or earlier, your primary care nurses, your GP practices, as well as other health professionals, especially because New Zealand has an indigenous population group, they have something called kaiawhinas, which is the Maori health workforce. And what they do is at that 5-month immunization or 6-month check, lift the lip of the child and see if the teeth are coming in, share some oral health advice, and they keep doing that at every visit, and it's part of the child's development booklet. And on the right, I've got a slide, a photo, which is actually in Samoan. That's because of New Zealand's high Pacifica population groups up around the Auckland and Wellington areas. But what it says is that's a before schools check. So at age 4, the kids are getting a comprehensive health check, and oral health is part of that check, and a referral is made to the dental practitioner or the dental therapist or the oral health therapist, who are the key part of the 0 to 18 workforce in New Zealand, so that oral health does not miss out. So those are 2 solutions that I think can be adapted into other countries. The second thing, which also builds on from Professor Donoff's earlier talk, is about having a team-based approach and using the whole oral health workforce. We are, as a sector, too small to be able to deal with the 3.5 billion active decay lesions on our own. And on the right, I've put in 2 slides. So if you look at the field of medicine and nursing, there is always 3 nurses to 1 medical practitioner. However, I've taken a slide from the UK Dental Register, and it shows that we have the ratio of mid-level dental providers to actually specialists and dentists is the other way around. Now, what I'm not saying is that we need to have less dentists. We definitely need to have more. But what I'm saying is that we need more mid-level providers as well, because in the remote and rural communities, we know that it's the issue and inequities can be resolved more by our mid-level professions. And it's been proven really well in places like Alaska, where you have the Native American people that actually train in New Zealand as dental therapists are serving their populations really well and have met a need that was there for a long time. Similarly, in countries like New Zealand, where dental therapy or dental nursing actually started in 1921, so 100 years since the beginning of the profession, the economic benefit as well as the clinical benefit of having a mid-level workforce has shown great benefit to meeting the oral health needs of the population. We're not there yet. All of the countries, even with the mid-level providers, are still struggling with the global increasing global need, and that's because if you look at the one large beverage company, their whole advertising budget for a year is $5 billion. In comparison, that's the similar amount to Singapore's whole health budget. So if a beverage company is spending that much money on advertising, we are actually definitely fighting a much bigger battle. And my last point, which builds once again from Professor Donoff's comment, is how do we expand our role in primary care? So I work as a CEO of a health service here in Victoria. And during the pandemic, we've actually all been stretched. And to give the frontline nursing and medical staff a break, we've actually been assisting with COVID testing. We've actually been providing vaccinations. And I was surprised to hear that in the States, it's only open to pharmacists. But if I look at Australia and New Zealand, they have utilized the dental and oral health workforces quite well in meeting the vaccination demand. And I think that should continue beyond the pandemic, because once the COVID vaccinations are delivered, there is still the fact that we have to deliver flu vaccinations on an yearly basis. In many developing countries or even developed countries where there's a higher level of socio-economic disparity, we see indigenous populations more likely having conditions such as rheumatic fever. And most of the swabbing is left to the primary care nurses and the GPs. However, if we are seeing the same patients in our practice, then our role should expand and we should be providing that service ourselves. Last but not the least, we also need to play a more active role in chronic disease management. We've always been working with the NCDs, and before oral health made it to the global health agenda at WHO level, we were always lumped with the NCD group because of the nature of the risk factors. And while we now are working towards our own strategy, we should still be partnering with the NCD groups because we have similar things we're trying to resolve. So I hope that the listeners would have got something out of that. And I will now hand over to Professor Shi, who will take us through the next session.
Thank you for inviting me. I would like to share some of our experience, some of our work related to integrate oral health and the general health. My name is Alan. I'm currently the president of Association for Dental Education, Asia Pacific, ADEAP. And I'm also the distinguished professor of School of Dentistry, National Yangming University. As we know, dental flora can induce some systemic disease like aspiration pneumonia or subacute bacterial endocarditis. So dental disease should be integrated into systemic disease. The percentage of the population with age above 65 in Taiwan now is around 17%. And it is estimated that in 2025, the percentage of people with age above 65 will be up to 20%. That means there will be 4.6 million elderly among 23 million people in Taiwan. And how to face the challenge of this so-called silver tsunami will be an important issue. The main challenge for aging or super-aged society in dentistry will be first, mastication, and the second, swallowing. To face the silver tsunami, many countries in Asia are emphasizing on these two issues. Japan is one of the leading countries in swallowing disturbance in terms of dysphagia. So our dental care will not be limited to oral cavity only. We can use either video fluoroscope or video endoscope to do the examination for those patients with dysphagia. So dentists will involve in the team of dysphagia with another professionals like a speech therapist, pharmacist, nutritionist, nurse, occupational therapist, social worker, physiotherapist, clinical psychologist, doctor, physician, and also, of course, the dental hygienist. And this is our young staff. They visited the nursing home in Japan. They learned how to treat those patients in the nursing home. Most of those patients in the nursing home, they suffered from at least 3 kinds of systemic disease. Each individual, they take 2,000 pills of medication in average per year. In these circumstances, how can the dentist treat those patients without integrating with knowledge of systemic disease? This is a study from Korea. And if you see here, it shows that cognitive impairment can be related to poor mastication ability. In my research team, we also studied the relationship of cognitive impairment and masticatory function by brain functional MRI. And this is our results. The results show that to maintain better masticatory function can maintain the volume of the gray matter of the brain. Thus, to maintain the brain in better function, to retard the process of cognitive impairment. And it also demonstrated that mastication is our business, and it should be also integrated with systemic disease like dementia. Based on this, we invited Professor Raman Bedi, this gentleman, and Raman is from the King's College, London, and he is in charge of the Global Child Dental Fund. And the lady is Bettina Borish. Maybe some of you knows her, and she's from Geneva. And she's the executive officer of WFPHA, that means the World Federation of Public Health Association. And with the minister, this one, the gentleman here, this Dr. Chen Shizhong, he's a Minister of Health and Welfare from Taiwan. And I'm very proud to say he's a dentist. And he thinks to integrate oral health and the general health is very important. And this is the announcement signed by those scholars and the minister. First is oral health. Sorry. Oral health is as important to general health as general health to oral health. And both parties have found themselves frequently, sorry, 小黑不见了，小黑，最后一张。小黑还是我。小黑这一张。And both parties have found themselves frequently separated in prevention, primary and specialized medical care, as well as in community programs to enhance the public's well-being. And oral health shares the same risk factors with other non-communicable disease and presents the same inequality, facing the most vulnerable in the population, being the less served, and the poor oral health coexists with occurrence and the consequence of non-community disease and the other health issues. Thank you. Thank you very much.
Thank you, Professor Allen. Now I will continue. I have been working on school oral health program for 15 years, and we developed dental immunization program, which has been accepted as Ministry of Health national regulation. But I'm very troubled because Indonesian National Health Research Survey 2018 has revealed that children with age 3 years old in average have 6 decays in the mouth. And that means when they reach schools, they already have 8 decays. So it is actually made me think that we need to move earlier before the disease happens. So this is why then we come up with innovative antenatal care, talking about healthy teeth, healthy baby. And this is an interprofessional collaboration initiative in Indonesia. So Sustainable Development Goals 3.1 has set out that by 2030, the global MMR should be reduced to less than 70 per 100,000 live births. And no country should have an MMR more than 140 per 100,000 live births. But this is our condition in Indonesia currently, and we are still quite far from the target. Ministry of Health released the maternal mortality by cause, and if we see these figures, then we can see that bleeding and preeclampsia has been a big source of the maternal mortality. When I tried to read over than 50 literatures, there is a connection or association between preeclampsia, preterm birth, low birth weight, and periodontitis. And this periodontitis was caused by the dysbiosis of oral microbiome of the mothers. And with this root, then we think that if we can do some intervention here or here before it becomes a irreversible disease, it can also help to avoid children from having early childhood caries. So from this theoretical framework, then we design the project. We understand that some of the intervention trials has reported contradictory results, but we think that oral health maintenance is an important part of preventive care that is both effective and safe throughout the pregnancy, and therefore should be supported before and during pregnancy. So oral health should be an important focus in the follow-up of pregnant women in every maternal and child health services, thus incorporating the diagnosis of maternal oral health and periodontal disease as possible risk factor. The oral microbiome being a key player in pregnancy, For healthcare practitioners, the oral microbiome offers a largely unacknowledged but significant system that fits into the fertility milieu. So the antenatal care innovative program goals, we are trying to get the ecology right from the start. We try to incorporating oral health diagnosis and prevention into routine antenatal care. The goal is to achieve healthy oral condition that will support systemic health during pregnancy, to achieve healthy and resilient family through oral health empowerment, and of course to deliver healthy babies. Our president hoping by the year 2045, we should have a superior generation. And I think superior generation start from having a healthy teeth. So the method that we choose is, number one, we have to work interprofessional between the midwife, dentist, and dental therapist. And also there will be oral care intervention in the form of biofilm diagnosis, plaque control, CPP, ACP, fluoride varnish, and also GIC fillings. In this picture, you will see that a group of midwives and dental professionals successfully team up and winning the game during the training that we gave them. And also dentists and dental therapists learn and show to midwives how to do tooth fillings. And also we show how to clean the teeth and removing the plaques using the correct toothbrush. So the process of the activity is, number one, we do initial survey of the situation on the pregnant mother's oral health. We specifically look at West Kalimantan, and then we do advocacy to West Kalimantan Provincial Health District and their 14 health district. The socialization and training to midwives and dentists and dental therapists. And then we do hope that district will do budgeting to sustain the program in the next financial year. After that, we will do socialization and assistance to pregnant mothers and their husbands. And then it will be followed by field penetration by 28 teams of midwives and dentists and dental therapists. Each will manage 12 pregnant mothers. From the district, from one district to another district is very far. So for example, we do the training here. And for those health workers that comes to the training, they have to travel 12 hours by car, and also those who stays in different districts. The initial survey of the pregnant mothers we have in one village in West Kalimantan, showing that 100% have active decays in the mouth. 15 from the 17 pregnant mothers have gingivitis. 15 from 17 have dental calculus, and 8 from 17 have missing teeth. So this is a long and winding road to the health. To access the pregnant mothers, the team has to go by car and then continue by a motorcycle. So this is the condition in Kalimantan. So this is the picture of our first offline trainings. The attendants coming from 14 districts travel very far just to meet offline. And because this is still in the COVID pandemic situation, then we applied a strict health protocols. The advocacy process to health district staff was fully supported by the Chief Provincial Health District, Dr. Harrison here. He also the one who provide all the budget for the activities for the pregnant mothers. So the first activity we have is training process for the health worker, starting from building commitments, getting the right mindset and expand the knowledge and also learn the teamwork. We found challenges at the end of our training that when the healthcare professionals do their self-checking, we found out that actually even the health worker have decays and 71% of them have decays, active decays. The policy implication of this antenatal care initiative is number one, integration of oral health into various programs such as maternal and child health, stunting elimination program, nutrition program, and etc. And secondly is there is a budgeting for oral health activities. And this is one of the health districts, Sintang, has already have a meeting today for budgeting for next year continuation activities. So in summary, oral health in low middle income countries suffers in many ways. Number one, because there is a disregard of their own oral health. There's a low skill on intervention, so treatment usually start with extraction as the first option. There's limited facilities, equipment, and relevant dental materials, lack of facility maintenance. Also, professional need development does not become the priority. There is a factor of limited fiscal capacity in the government. Government focus on high priorities such as maternal and child health. So the solution that we can think of is there is a need to capacitate the dentistry profession in a way, synergizing always to high priority systemic health programs such as maternal and child health, stunting, non-communicable disease like diabetes, hypertension, etc. So with this, I will close my presentation and thank you very much for your attention.
Thank you very much, Dr. Admaka, and all of the wonderful speakers. Those are really powerful presentations. And we're going to get to questions now. We're going to run 15 minutes over because those are such incredible presentations. I know you'll have a lot of questions, so please put your questions into the chat box. And I want to start off with a question that has come from a colleague in somewhere in Africa, Ephraim. And Ephraim, it's the central point that many of you have touched on, is that oral health, oral hygiene, oral diseases, should I say, are very prevalent amongst children and adults on the continent of Africa. His question is, how do we ensure equitable access to the oral health interventions that you've mentioned in a region of the world where oral health has been deeply neglected, and many countries are quite impoverished and have very small budgets for this. So is anybody would like to tackle that for Ephraim? How do we improve, reduce the burden of oral health in low-income countries? What would be the top 2 or 3 things to do? Who would like to start off with that?
Well, one thing you could do is to try and develop dental professionals of some cases. We've done that in Rwanda. And I think there's a new dental school starting in another state in Africa. But I think the most important thing is to make oral health part of visits of patients when they come to clinics for other reasons. If they're coming for an infection or a cough, make sure that someone can look at, someone at least looks in their mouth and sees what's going on. I think that could help so many of these patients in these areas travel miles.
Yeah. Well, Doctor, let me then I'm going to ask Dr. Naresh and then Dr. Adyadmaka to add to your comments, because both of you are doing work. Dr. Naresh, you mentioned the lift of the lip. Dr. Adyadmaka spoke about utilizing obstetrics and accessing pregnant women to improve health outcomes. Dr. Naresh, did you want to expand on what Dr. Donoff mentioned, and then Dr. Adyadmaka, what you're doing in Indonesia? Please, Arish.
Thanks, Keith. I think what I was going to say is I've done some work in Cambodia as well, in much in a volunteer capacity, and they have similar issues there. And they've been using silver diamond fluoride as a solution to combat some of the higher levels of decay. It's probably not the best way to go about things, but in the absence of having a large workforce and a large budget to combat the issue, I think that's an intermediate solution. And I think what they've also done, which I liked, was they've been training the primary care workforces to be able to apply silver diamond fluoride with appropriate training. So at least that's providing, caries that are arrested and saving the teeth from getting into an abscessing stage. So it's an intermediate solution.
Thank you, Dr. Naresh. Dr. Adyadmaka, how do we expand the work that you're doing with midwives into other professions?
Yes, thank you, Dr. Keith. I think from the question is about school oral health. I have an experience of tackling the school oral health program in low middle income countries like Indonesia. And I think what is very important is building the empowerment on the community. Many times we think that community is just an object. So we think they don't know everything and cannot do everything. But actually, we have proven that even the lowest social economy, they would like to stand on their own feet. So by giving them the empowerment of how to do the correct oral health practice for themselves and their families, I think we can change many lives. That's what I experienced. Thank you, Dr. Keith.
Thank you, Dr. Adyadmaka. Dr. Shi, Taiwan has a really superb public health system, hence just the outstanding job that you've done in addressing the COVID-19 pandemic in your country. Can you share with us how the government of Taiwan has effectively been able to integrate public health measures, whereas other countries have not? How was that realized? How were the obstacles overcome, and how did the government of Taiwan, being such a leader in public health in so many ways? Maybe we lost Dr. Shi. All right, maybe somebody else would like to really respond to it. How do we become more effective at addressing getting governments to adopt the public health policies that can address some of the risk factors for oral health diseases, such as high sugar foods, tobacco, alcohol overconsumption? Anybody have any thoughts about that? Maybe Dr. Donoff, did you have any ideas about that from Harvard?
With difficulty. This is a matter of, it reminds me of a wonderful book, Innovations and Its Enemies. I think reduction in sugar drinks has its enemies in the people in the companies that produce sugar drinks, et cetera, et cetera, et cetera. And I think there has to be negotiation and some kind of organizational clout behind that, with a lot of, at least in our country, at least lobbying that's as strong as the industry lobbying. It's just amazing how we've not been able to make any inroads in that. We don't prevent, we only treat. And I think that's consistent, at least in our country, in that you get paid for treating, not for preventing.
Indeed, that is a chronic challenge, but the value proposition is there to do exactly what all of you are saying. Dr. Naresh, do you want to add to that?
Yeah, and I think Professor Donoff has very clearly said about the commercial agenda, and we know that we spend more research money in finding out the next best implant than what the population level solution should be to preventing dental decay. I think for me, the timing is just right. We've waited a long time, and the analogy I would use is oral health has been just like the ugly sister to Cinderella services, but it's now our time to shine because we finally have a strategy in development. And part of the strategy roadmap is that in 2022 and 2023, there will be a set of global indicators as well as a action plan that goes with it. And I think as a sector, as leaders in this group, plus the audience that are watching, we should be collectively advocating to have the right indicators in there and then use those indicators to hold people to account. And that may provide us solutions in the long term. Do I believe we'll get oral health for all by 2030? I think that's highly ambitious. But do I believe that we are on the right trajectory? I think after this year, we are.
Wonderful, thank you. And I just want Dr. Brittany Seymour, who did a superb job of leading our global oral health interest group before Dr. Aditmaka has taken this on, and she herself has done a superb job, brings to our attention the work that they're doing with the WHO on training community health workers. So please take a look at that if you have a chance to do that. I want to place a question coming from Henry, and I'm going to add this with a couple of other questions here, which really amounts to how do we actually do a better job of systemically reforming health systems to integrate oral health into primary care? What are some of the obstacles and how do we overcome them? Irene, did you want to take that? Maybe not sure, Irene, if we lost you, at least temporarily.
Hello.
Yes.
Sorry.
That's all right.
Okay. So answering the question, what is the significant change suggested in healthcare policies to better and effectively integrate oral health with the primary care? In my experience, talking about oral microbiome is always a gate for bringing the importance of oral health to systemic health. So I think the topic of oral microbiome should be look deeper, and because explaining the oral microbiome and the health systemics is the very logical thing that ordinary people can accept. So I have been using this strategy to make an ordinary people understand about the importance of oral health that will create a systemic problem if they neglect it.
Wonderful. Thank you very much. Thank you. We're coming towards the end of our session today, and I want to thank all of you for putting in your questions. I'm going to go back to our speakers to see if they have any final closing comments, and we'll go in the reverse order that we started. So Dr. Antenatal will go first, and then Dr. Shi, if he's still on. We may have lost Dr. Shi, then Dr. Naresh, and then Dr. Donhoff, and I'll finally close. So Dr. Ajimaka, please, any final comments or points you want to make?
Yes, I think this is a new era where oral health is a strategic entry point to systemic health. And we would like to invite any helping hands for our low middle income countries. Thank you.
Thank you, Dr. Ajimaka. Dr. Shi, if you're still on. I think we lost Dr. Shi. Dr. Naresh, please.
So my final comments would be that due to the global pandemic, there are two silent pandemics that are happening. One is mental health because of the lockdowns and everything else. And the second was definitely oral health, because we have had to delay care. And if you look at the NHS, you know, just over 1 million appointments were cancelled over the 12 months. So when we all reopen and get to the new normal, we'll have to really think differently. We'll really have to work with our patients and the communities to deliver care in a different way. Because if we go back to the treatment models and only, you know, looking at the tooth, the whole tooth, and nothing but the tooth, then we'll be back in the same place. So it's about reframing the narrative and looking at the world of oral health from a population health perspective. Thank you.
Thank you, Dr. Naresh. Dr. Donhoff, please.
Well, I think that's a very important question. I would offer two potential solutions. The first is teach medical students something about the mouth during their education and training. That would be helpful. And secondly, I'm a great believer in creating champions who belong to the same club. And to that extent, I think we do need dually trained people who can function in both areas. Not many, but a few good ones.
Wonderful. Thank you, Dr. Donhoff. And I think in closing, we've heard very powerfully the importance of oral health, and it's been neglected for decades and decades. We actually know what to do. There's simple public health interventions can be deployed, and it's interesting to governments who can make these decisions and our professional associations is that there's an enormous value proposition to doing so. And if we focus on making sure that we put our patients at the center of what we do, we can collectively across disciplines fight for those interventions that can vastly improve their health and socioeconomic outcomes. I think we heard very clearly from Dr. Donhoff the importance of implementing these actionable items for integrating oral health into primary care. Dr. Naresh gave us some very important examples on how to do that from New Zealand on early intervention. The caries you have at age 6 and the caries you have at age 36 are very, very similar. His Lift the Lift program is one of those examples. And using the whole health workforce to be able to address this challenge. We heard from Dr. Shi in Taiwan, the importance of dealing with an aging population that gets neglected, and yet chewing and swallowing are two huge public health challenges that we neglect and are frankly ignored, but they'll become increasingly important as we all age and all countries will face this aging population. Dr. Adit Maka closed with showing about how early intervention and can make an enormous difference in how the oral microbiome is critically important for oral health. And she used the powerful example of how we can actually work with those involved with midwives and those involved in obstetrical care to actually capture a population, pregnant women, to improve not only their oral health, but also their systemic health. And I think finally, it's important for all of us, regardless of the profession that we're in, is that if we're able to go and work together, we can actually pressure governments to scale up and implement the very important public health interventions that can address the risk factors for oral health diseases, high sugar content foods, alcohol overconsumption, and tobacco. In addition, working together across our disciplines between nurses, physicians, and dentists, we can improve the scope and access to oral health, whether you're in, as our first question had, on the continent of Africa, or whether you are in Boston. All the world needs greater access to affordable, accessible, and quality oral health. With that, I'd like to thank Jenna Smith, who leads these efforts on our team here, Dal Najjar, who's been backing her up, and all of you for joining us on this oral health webinar. Please come and attend and register for our conference, where this will be addressed by Dr. Antenatal and her Global Oral Health Interest Group, which I hope you'll be able to join. Our conference is next March, and you can register for it at cugh2022.org, and it will be entirely virtual. So wherever you are in the world, you will be able to attend it. Thanks for joining us today. We will see you soon. Bye for now.